So, hello friends, I hope I'm audible and visible. Can you all give me a quick thumbs up if my audio video is fine? Let me check if you all can hear me properly. This is a very important image-based session which I wanted to discuss with all of you. So, let us begin with the today's class with a very important regular discussion. So, I'm Dr. Chesta Agarwal, your NEET PG educator, and we have recently introduced the Unacademy NEET PG notes. So, anyone who is preparing for NEET PG 2022, you can definitely buy this notes as you will get a 1 year subscription for free in this. We do have a plus subscription which give you an access to both Unacademy and in Iconic which give you an access to Unacademy and Prep Ladder. So requesting all of you to please kindly get your Unacademy subscription. I congratulate to all the toppers who have cleared their exam. And for the month, for the remaining part of this month, we have a lot of important MCQs uh, or important MCQ based sessions which is available. I think there is no problem in my connection, right? ठीक है. Okay, जी, fine. So we do have a lot of special classes. I take one special class every day at 2:30 p.m. So I'm requesting all of you to please be live for this. New batches which have started recently is the FMG batch and the next batch. And this is the price list. I request all of you to please get yourself enrolled. The 3 month subscription is a very popular subscription for those who are giving the exam in the mid-year. They can use my code CHESTA10 to get additional 10% discount. So anybody who is interested in Unacademy subscription, please kindly use this code so that you can access all my or you can get a 10% additional discount on all the Unacademy subscriptions. So starting with the first question, all of you here, what is the correct answer of this question? This is a picture of. This is a picture of requesting all of you to kindly answer this question. This is a picture of Pemphigus foliaceus, bullous pemphigoid, Pemphigus vulgaris, or chronic bullous dermatosis of childhood. What is the correct answer here? Anyone? A picture of Pemphigus foliaceus, bullous pemphigoid, Pemphigus vulgaris, or chronic bullous dermatosis of childhood. The correct answer here is option number. Anyone? Option number 1. Now, why it is option number 1, not option number, why it is option number 3, not option number 1? The reason is in Pemphigus foliaceus, we only see scaling and crusting. But if you see in this image, you can see the flattened or settled bulla. Can you see this? There is a lot of settled bulla which is visible here in these individuals. So this is how you differentiate a Pemphigus foliaceus patient from Pemphigus vulgaris. You can get more history that if the oral lesions are present, it will point more towards the diagnosis of Pemphigus vulgaris. Next question is again an image based. What is false about this patient, this condition? What is false about this condition? Itchy, pigmentation, alopecia, stretch mark. What is the correct answer? False about this condition would be very nice, Prasanna. Now please look at this image. Now there is a patient who presented with a history of small lesions. Can you see it here? They are papules, which are very flat topped, polygonal, and purple in color. So this is a very classical example of lichen planus. Very classical image of lichen planus. And in lichen planus, you will never see stretch marks because patient will not excoriate, patient will rub the lesion. You can see itching, you can see pigmentation, you can see alopecia, but stretch mark is never seen in a patient of lichen planus. Next question. This is one of my own patient. What is the true association? What is the true association? Nemogene, CARD45, NER defect, SOR1. What is the Nemogene? Very nice. Prasanna, Achan. True associations, Nemo gene, CARD45, NER defect, or SOD1. The answer is option number 3. This is a very classical image of xeroderma pigmentosa. A very classical image of xeroderma pigment. Can you see that there is some scarring which is present on the nose, on the cheek, and there is some crusting which is also present. This is a patient where you have photosensitivity because of defective nucleotide excision repair. There's a lot of freckling which you see here. So the answer to this question is option number. Clear? Next question is on your computer screen. Which of the following is the correct match? Which of the following is a correct match? Which of the following is a correct match? Anyone? The answer to this question is option number 1. This is an example of neurofibromatosis type 1. This is an example of neurofibromatosis type 1, and please remember in neurofibromatosis type 1, the cafe macules appears first in the disease. Neurofibromatosis 1 is chromosome 17 defect, and neurofibroma should be more than equals to 2 for making a diagnosis. The only correct statement is axillary freckling is pathognomic. Next question. History since 2 years. What is the answer? History since 2 years. What is the diagnosis? Anyone? Okay, very nice. The correct answer of this question is option number 1. Now, if you look at this lesion, you can see that there's a lesion on the inner canthus of the eye. There's a lesion on the inner canthus of the eye. And when you examine it, you can see that there is scarring at few end, crusting at few end. There is margin which is beaded. At few area it is present, at few area it is normal. So this is a very classical image of basal cell carcinoma. Next question. What is the answer? A 23-year-old lady develops pigmentation on the cheek with photosensitivity. What is the diagnosis? Very nice, Rakesh, Prasanna, Achan. If I show you the image first, look at the image. There's a middle-aged to young female. You can see pigmentation over both the cheeks, slight pigmentation over the nose, and even it is extending onto the upper lip. This is a patient with photosensitivity also, classical of melasma. Very nice. Identify these scales: colorate scales, micaceous scales, ichthyotic scales, or mica-like scales. What are these scales which you see in these individuals? Prasanna, Rakesh, anybody else? Achan, identify these scales: collar-like scales, micaceous scales, ichthyotic scales. What is or which is the correct answer? Amazing, all of you. Very, very nice. The correct answer of this question is option number 3. Ichthyotic scales. The correct answer is ichthyotic scales. You can see that there is a fish-like scales, dry patches seen in the patient's hand. Ichthyotic scales. These are nothing but the ichthyotic scales. Next question. Shri, Rakesh, Prasanna. Achan. Child with sores in the mouth and a rash on the hand, feet, as shown in the image, which can be the causative agent? What is the causative organism for this? Coxsackie A16, pox virus, herpes virus, or human papilloma virus? Or human papilloma virus. Coxsackie, pox, herpes, or human papilloma virus. Anyone? Very nice. Now here the lesions are mainly on hand, foot, buttock, and mouth. So this is a case of hand, foot, and mouth disease. This is a case of hand, foot, and mouth disease. And this hand, foot, and mouth disease, what is the causative agent? Coxsackie A16. Very nice. Coxsackie A16. So Richpal, Rakesh, then Shri, Prasanna, Achan. Very nice. 15-year-old boy with intense itching since 1 week. Examination shows large circular areas on the back. We have solved this same question in the special class recently. Anyone can tell me the answer? Very nice. The answer to this question is option number one. Classic annular lesion with central clearing is seen in the patients of tinea or dermatophytic infections. Patient with foul smelling, patient with following lesions on the face, where you have scarring in the center and increase in the lesion on the periphery. So just look at the image. Just look at the image first. There is a large plaque which is present on the cheek, even extending onto the earlobe. And if you look at the margin, there is erythema. Look at the margin, there is erythema. So what can be the diagnosis? What is the diagnosis? Very nice. The answer to this question is option number three. And what is this an image of? This is an image of lupus vulgaris, cutaneous TB, and you have to give anti-tubercular therapy here. Next question. Question number 18. 18-year-old male with this rash, what can be the diagnosis? 18-year-old male with this rash, what can be the diagnosis? Systemic sclerosis, dermatomyositis, SLE, or Sjogren syndrome. Anyone? Very nice. Systemic sclerosis, dermatomyositis, SLE, Sjogren. The answer is option number two. Now look at these images. If I focus on image number one, can you see this thickening on the knuckles of this patient? This is a very classical image of the Gotran's papules. You can see that the hands are very like a mechanic, so it is the mechanic hand. And if you look at the face, you can see that there is some erythema around the eyes. So this is heliotrope rash. So this image is heliotrope rash. This is Gotron papules or plaque. And this is mechanic hand. This is mechanic hand. Okay. So we have Gotron papules, plaque, mechanic hand, or heliotrope rash. Answer is option number 2. Next question. The patient with flat lesion on the face which are increasing gradually. Let me just show you the image. Look at this image. What is the answer? You can see some lesions on the face. What is the answer? The male with flat lesion on the face which are increasing gradually, the diagnosis would be. What is the correct answer here? A male with flat lesion on the face which are increasing gradually, the diagnosis would be verruca plana. Just look at these lesions. They are flat-topped hyperpigmented lesions which are present in a large number. That is how plain wart or verruca plana look like. That is plain wart or verruca plana look like. So not 2. Option number 3 is correct here. Okay? Staphylococcus and Rahul, it is option number 3 which is correct here, not option number 2. Moving to the next question. Child with history of diarrhea and falling skin manifestation, what is the answer? Anyone can tell me the answer here? Very nice. Amazing. I think it's a very easy question. You can see that periorificial dermatitis. Periorificial. You can see periorificial dermatitis. Okay? And this is a very classical feature of periorificial dermatitis, the feature of zinc deficiency, which is known as. Clear, all of you? Next question. Now you have to tell me what is the answer. Anyone can tell me the answer? A 20-year-old boy with circular areas of complete hair loss, the most likely expected nail finding would be. Please remember the correct answer here is this is a case of alopecia areata, and the most expected nail finding here would be geographic nail. You will see pitting, which is uniform. You will see uniform pitting. You will see uniform pitting here. Please tell me what is the answer here. Shri, the serotype which causes the plain warts, it is HPV 3 and 10, which causes plain wart or verruca plana. Diagnosis of a man with hair loss involving crown and the frontal part. What is the answer here? Yes. So when there is no maintenance of the frontal hairline, it becomes male pattern androgenic alopecia. It becomes a very classical of male pattern androgenic alopecia. Male pattern androgenic alopecia, which is also known as Hamilton and Norwood classification. You must have heard this Hamilton and Norwood type of classification. Rakesh, Shri, Staphylococcus, Dr. Richpal. You were called in the emergency department of an infant who developed skin exfoliation. Mother gives a history of fever. The vitals are stable. What could be the diagnosis? Anyone? What can be the diagnosis in this question? Can you see the image? Let me just elaborate or let me just focus this image. Look at this now. You can see that there are skin which is getting peeled off. Skin is getting peeled off here. So what will be the answer? Please remember the answer to this question will be staphylococcal scalded skin syndrome. Staphylococcal scalded skin syndrome. Clear hai? Now what happens in staphylococcal scalded skin syndrome? There is a toxin which is released by staphylococcus, which is the exfoliative toxin, which is the exfoliative toxin. The toxin which is released is the exfoliative toxin, and this will go and damage desmoglein 1. So the patients develop what? Patient develops a very superficial erosions. Subcorneal splitting occurs here. It is not a case of epidermolysis bullosa simplex or impetigo or congenital syphilis. That is not the case. Now, patient develops the lesion on the forehead and on the genitals. Patient develops the lesions on the forehead and the genitals. What is the answer? He gave a history of unprotected sexual intercourse few days back. What is the answer? Very nice. Please remember it's a pox virus infection, which is nothing but molluscum contagiosum infection. It is molluscum contagiosum. It's a pox virus, which is molluscum contagiosum infection. Pox virus, which is molluscum contagiosum. Next question. What is the answer here? A 10-year-old boy with painful bogey swelling of the scalp, multiple sinuses with purulent discharge, easily pluckability of the hair, lymph nodes are enlarged in the occipital region. Which of the following would be the most helpful for making the diagnosis? Biopsy, bacterial culture, KOH mount, or a patch test? What is the answer to this question? Very nice. The answer is KOH mount, because can you see this image? There is a patient, a young patient, a prepubertal individual with a bogey swelling on the scalp through which there are multiple discharges coming out. So when you see this alopecia patch with sinus tracts in a prepubertal individual, you think about chirion, which is nothing but it's chirion, which is nothing but a part of the fungus of the scalp, Tinea capitis. Moving to the next question. Moving to the next question. 35-year-old male develops red oval macules after taking metronidazole. History of similar lesion at the same site 6 months back. What is your diagnosis? Erythema multiforme, urticaria, annular LP, or fixed drug eruption? Or fixed drug eruption. What is the answer here? Look at this image, very, very characteristic. You can see that there are purple lesions with red margins, erythematous margin, purple lesions with erythematous margin. What is the correct answer? The answer here is fixed drug eruption. When a patient takes a drug, he develops these lesions. If patient takes the same drug for the second time, he will develop the lesions on the same site. So that is fixed. And whenever you have healing with hyperpigmentation, and that can be easily visible. You can easily identify the sites where these lesions happen. You can easily see the sites where the lesions happen. Female with hyperpigmented patches on the hair, or there is hairs with hyperpigmented patches on the lower body. What is the diagnosis? Congenital melanocytic nevus, verrucous epidermal nevus, lentigens, or melanoacanthoma. Anyone? Rakesh, Kaustubh, Paras, Shri. Look at this image. There's a very large hyperpigmented lesion and there's a lot of hairs which is present over it. What can be the diagnosis? This is an example of giant congenital melanocytic nevus. You call it as giant when the size is more than 20 centimeters square and you have associated hypertrichosis. It is important because this is a pre-malignant condition, can convert into malignant melanoma, and these patients need to have a regular follow-up. So if there is any problem, we can quickly remove that part which is converting into malignancy. Next question. Eczema which can lead to these conditions are all except. Eczemas which can lead to these conditions are all except. What is the answer? Anyone? Very nice. The answer to this question is option number 4. Now, I just want to put this image because I wanted to show how does a erythrodermic or erythroderma look like. How does erythroderma look like? Whenever you have a patient with more than 90% of the body having redness, scaling, may or may not be associated with itching. This is known as erythroderma. And please remember, erythroderma is sometimes very popularly known as what? Exfoliative dermatitis. So this is a case of exfoliative dermatitis. This is a case of exfoliative dermatitis where more than 90% of the body surface area is red. You have fine scales which is coming out, and this is seen in the patients with pneumolar eczema. Clear, Aji? Next question. Okay, so I'm just shifting it a little lower so that you can have a look. Please tell me the answer. Rakesh, Kaustubh, Shri, Jewels, Staphylococcus, Richpal. Anyone can tell me the answer here? The ulcer with overhanging and undermined edges in the neck region as shown in the image given below, what can be the diagnosis? So I think this is a self-explanatory image. Just look at this image. This patient presented to us with some enlargements on the neck, and over the top we can see some crusting. So this is actually a case of scrofuloderma or tubercular lymph node, and for treating this patient you need to give anti-tubercular therapy. The dosage is same like that of pulmonary tuberculosis, where you have to give the 2 month of intensive and 4 month of continuation phase. Next question. Alcoholic with history of diarrhea and delirium, what can be the diagnosis? What can be the diagnosis in an alcoholic with diarrhea and delirium? Rakesh, Ashmita, Kaustubh. Again, showing you the image, a very classical image. Look at this. There are well-defined lesions which are mainly present on the exposed part, that is the lower limb. So this patient gave us a history that he always wear the lowers like that. This is a full dhoti, but he always ties it upward while doing the work. So the lower limbs are getting exposed. Very nice. The correct answer is niacin deficiency. The correct answer is niacin deficiency or pellagra. The correct answer is niacin deficiency or pellagra. Clear? Kaposi verrucoliform eruption. Kaposi verrucoliform eruption is. So you can see this image. Here you can see a lot of vesicles which are present on the genitals, around the face in this patient. So first of all, tell me what can be the diagnosis? Varicella-like grooved vesicular lesion in Kaposi sarcoma. Infection with herpes virus in the patient with atopic dermatitis. Infection with HHV8 resulting in cutaneous exanthem distributed centripetally. Maculopapular rash due to cutaneous hypersensitivity following Kaposi sarcoma viral infection. What is Kaposi verrucoliform eruption? What is Kaposi verrucoliform eruption? Yes, the correct answer is option number 2. It is also known as eczema herpeticum. It is also known as eczema herpeticum. What is eczema herpeticum? In a patient, those who have underlying atopic dermatitis, because of defective barrier function, they tend to have diffuse lesions. They tend to have diffuse lesions of, yes, diffuse lesions of herpes simplex. And this diffuse herpes simplex lesions, they are called as Kaposi verrucoliform eruptions. Very nice. Identify this physical urticaria. Look at the back. Patient says that whenever he scratches the back, he tend to develop these lesions. Whenever he scratches the back, he tend to develop these lesions. So what is the answer? Identify the physical urticaria. Dermographism, urticaria pigmentosa, urticaria vasculitis, or autoimmune urticaria. Rakesh, Kamal, Kaustubh, Ashmita, anyone? Taras. This is a case of physical urticaria which is known as dermographism. This is a case of physical urticaria which is called as dermographism. Very nice. Next question. The patient with rash in more than 30% of the skin area, hemorrhagic crusting on the lip, what can be the cause? Drugs, virus, malignancies, or bacterial infections. Drug, virus, malignancies, or bacterial infections. First of all, think about the diagnosis. What can be the diagnosis here? What can be the diagnosis? I can zoom this image for you where you can see that there's a lot of hemorrhagic crusting and there's a lot of targetoid lesions. What is the answer here? The answer is the diagnosis, first of all, it is toxic epidermal necrolysis. Because more than 90% of the body surface area is getting exfoliated. And the cause here would be drugs. Drugs is the most common cause of. It is not SJS. Rakesh, for SJS, please remember the body surface area involved is less than 30%. Okay, less than 10%, not 30%. What is the answer here in this question? A male patient with the patchy hair loss. Anyone can tell me the answer? Anyone can tell me the answer here? Patient with alopecia areata. And why there is sudden graying of the hair? Because in alopecia areata, the T lymphocytes, they are directed against the pigmented part of the hair, that is here. So the T lymphocytes are actually directed only against the pigmented hair. So the non-pigmented hairs are usually spared, and that is why you tend to see the sudden graying or graying overnight phenomena, which is very classical in the patients of alopecia areata. Moving to the next question. Identify this condition: nevus of Ota, nevus of Ito, Mongolian spot, or hypomelanosis of Ito. Ashmita, Shweta, Kostu, what is the correct answer here? I can just elaborate this image. Look at this image. There's a large area which you see. And here, if you note, look at the color, it is not brown in color. It is little bluish, greenish color. So what is the diagnosis here? Very nice. The answer to this question is nevus of Ota. If same thing occurs on the upper part of the or on the scapular region, shoulder region, it is known as nevus of Ito. And same thing over lumbosacral area, it is known as Mongolian spot. So these three are the examples of dermal melanocytic proliferation. They are the examples of dermal melanocytic proliferations. Dermal melanocytic proliferations. Next, first line treatment for acne comedone. What will be the first line treatment for the comedones? It's a repeat question, PYQ. What will you see? Or how should you treat the patients of acne comedone? We have discussed that acne comedone is the grade 1 of acne, and the main problem is hypercornification. Hypercornification of the follicular opening, which can be treated by topical retinoids. Which can be treated by topical retinoids. Next, identify the condition shown in the image. So this is one of my own patient who presented to me with the complaints of these lesions. She was pregnant also, and she said that the lesion was present before pregnancy also, but now during pregnancy it has suddenly increased in its size. Now it has suddenly increased in its size. So what can be the diagnosis? Very nice. Please remember the answer here is genital wart, or we are actually dealing with HPV 6 and 11 infection. Now, if this is a pregnant patient, you can never give podophyllin or imiquimod. The treatment option available would be TCA or cryotherapy. Because podophyllin and imiquimod, they are teratogenic drugs, so they should be avoided in a pregnant female. And if you look at this image carefully, you can see one more lesion. Can you see these lesions here? This is actually fungus. So this pregnant female had both tinea also in addition to that of the verrucous lesion. And please remember, it is very important for us to treat the viral warts, because if a pregnant female has viral wart on the external genitals, it is an indication of cesarean section. You never advise a normal delivery in the patients with genital wart, because it can give rise to the nasopharyngeal warts in a newborn because of inhalation. Next question. Patient of lepromatous leprosy was started on treatment. He develops ENL with fever. She also reports a change in her skin color after therapy. What can be the likely drug which is responsible for this condition? The likely drug responsible for this condition. Likely drug which is responsible for this condition. Very nice, all of you. Clofazimine, rifampicin, thalidomide, or prednisolone. The answer to this question is option number 1. Now please look at this image. You can see that there's a patient with a lot of hyperpigmentation on the face. And the question is mentioned that the treatment was started for lepromatous leprosy. So in anti-leprosy drug, in MDT leprosy, one of the drug is clofazimine, and clofazimine causes a lot of pigmentation. Next question, look at this image. Can you see a very cold sort of ulcer? The history is it is a non-tender and hard ulcers on the genitalia without any lymph node enlargement. What can be the diagnosis? What can be the diagnosis in an ulcer which is non-tender and indurated? Anyone? Syphilis, LGV, herpes, or chancroid? What can be the answer here? Nice. The answer to this question is syphilis. Please remember, in syphilis, you get non-tender indurated ulcer, and in only 60 to 70% of the patient, you see associated painless lymphadenopathy also. So it is not in 100% of the patient. So even without lymph node enlargement, you can get lesions of syphilis. Next question. A patient comes with itching in the groin since 2 days. All causes this except aspergillus, trichophyton, microsporum, epidermophyton, etc. What is the correct answer? Rakesh. Then we have Kaustubh, Ashmita. Patient comes with itching in the groin since 2 days. All can cause this except aspergillus, trichophyton, microsporum, or epidermophyton. Very nice. This is a very classical example of tinea. And most frequently, it is looking like corporis, which is extending to form crudis. Tinea is a dermatophyte infection, and we have only three species of dermatophyte. What are those three species? We have trichophyton, we have microsporum species, and we have epidermophyton. So these are the three species which we have in our skin. Three species which we have in our skin. Patch test is done to document type 1 hypersensitivity, delayed type hypersensitivity, autoimmune disease, or immune complex deposition. Patch test is done to document. Anyone? Very nice. Patch test, which is the investigation of choice for allergic contact dermatitis, it usually demonstrates type 4 hypersensitivity, which is a delayed type of hypersensitivity reaction. Now, here first, I want all of you to just have a look of the image. You can see that there's a patient with lot of pustules, which you can see here. They are discrete at few places. At few places, they are combining together to form the large areas or large lakes of pus. What can be the diagnosis? He is a patient who is treated with steroids, and on stopping the treatment, he develops fever, malaise, and the pustular lesions. Very nice. The answer would be acute generalized pustular psoriasis, because we never treat a patient of psoriasis with steroids, and if we by chance treat, we can get the patient these lesions, which is pustular lesions. Next question is on your computer screen. The next question is on your computer screen. 45-year-old male with history of itching, papules over the face, neck, V area of the chest for last 3 years, which were exacerbated in the summer, improves in winter. What test will you do to confirm the diagnosis? What test you will do to confirm the diagnosis? Anyone? Very nice, all of you. This is a case of chronic actinic dermatosis. Chronic actinic dermatosis. Very nice, all of you. I can see a lot of you with the correct answer. Uh, Narmata, Rakesh, Nivta. It is chronic actinic dermatosis, which is nothing but chronic form of photodermatitis, which is a exogenous allergic contact dermatitis. And for testing this, we have already discussed that the investigation of choice is a patch test. Next question. Look at these lesions. You can see that the elbow of the patient is red. Can you see the elbow here? The elbow here. You can see some lesions. So 3-year-old boy has itchy, or 3-year-old child has a itchy eczematous dermatosis. On the flexural area, mother has a history of bronchial asthma. What can be the diagnosis? Ayush, Rakesh, what can be the diagnosis here? Atopic dermatitis, contact dermatitis, or infantile seborrheic dermatitis. Which of the following will be the answer? Amazing, all of you. So the correct answer in this question would be option number one. Atopic dermatitis is a pure clinical dermatitis or pure clinical diagnosis where you should have at least two major or three minor criteria in addition to itching that should be positive. So itching plus one major criteria of flexural dermatitis and another major criteria of family history of atopic points towards the diagnosis of atopic dermatitis. What is oral thrush also known as? There's an image attached. What is the oral thrush also known as? Anyone? What is the oral thrush also known as? Good, very nice. Oral thrush is also known as acute pseudomembranous candidiasis. It is also known as acute pseudomembranous candidiasis. Next question is on your screen again. Female with this lesion, which has increased in puberty, look at this image, present on the body, scapular region. When you compare this part from this part and this part, the hairs are also more here. And the lesion have started specifically at the time or around the puberty. So what can be the answer? So female who develop this lesion, which has increased at the time of puberty, it's a very classical image of Baker's nevus. It's a very classical image of the Baker's nevus. Next question. Identify this condition. Dystrophic calcification, tuberous xanthoma, lipoma, or phrynoderma. What is this condition? Ayush, Narmata, Bablu, Farooq, Rakesh. Anyone? Identify this condition, dystrophic calcification, tuberous xanthoma, lipoma, or phrynoderma. Very nice. The answer, correct answer of this question would be option number, that is tuberous xanthoma. Tuberous xanthoma is the correct answer for this question. A housemaid presented to dermatology OPD with these lesions since 15 days. What can be the diagnosis? A housemaid who presented to derma OPD with these lesions since 15 days. What can be the diagnosis? Very nice. This is an example of irritant contact dermatitis. And please remember, this detergent dermatitis is the most common cause of contact dermatitis in our country. Detergent dermatitis, also known as housemaid's dermatitis, most common cause of contact dermatitis in India. Next question. The defect is here. If I focus the image, here is the defect. Can you see this S-shaped lesion? It is associated with intense itching and burning sensation. Associated with intense itching and burning sensation. What is the diagnosis? Anyone? Very nice, very nice. The answer to this question is cutaneous larva migrans. I hope you all can see this image. Can you give me a quick thumbs up if you can see this image? Yes, so this is a very classical case of cutaneous larva migrans. And when this larva moves, it causes a lot of itching in the patient. So that is what is given here. Next question. Which form of candida has satellite lesions? Which form of candida have satellite lesions? Which form of candida have satellite lesions in them? Very nice. It is the candidal intertrigo. It is the candidal intertrigo which has these type of satellite lesions. Now, it is a there, A lot of dermatitis also you see a very similar lesion. Although you will not see diaper in any other part, you will see it mainly on the lower part where you tie a diaper. But the issue is to differentiate it from candidal intertrigo is little difficult. So how do you do this? In candidal intertrigo, you will see that flexures are involved. But in diaper dermatitis, you will see that only the convexity is getting involved. So that is the difference. Moving to the next question. Moving to the next question. 6-year-old child presented with these lesions associated with itching. What is the diagnosis? Seborrheic dermatitis, alopecia areata, or trichotillomania. Please remember that in a prepubertal individual, tinea capitis is more common. When you see a scaly lesion over the scalp, although here it is very clear that there are a lot of swellings, bogey swellings which are present. But in a post-pubertal individual, tinea is not very common because the seborrhea which is produced by the body, it actually has an antifungal property in them. And seborrhea occurs only after puberty. So that is a difference which you need to know. We have a 30-year-old patient presented with annular plaque with central crusting. What will be the answer? Ayush, Narmata, Rakesh, Farooq. 30-year-old patient with annular plaque, central crusting. What can be the diagnosis? Lupus vulgaris, cutaneous leishmaniasis, DLE, or tinea corporis. The answer is option number. Cutaneous leishmaniasis is the correct answer. Now, if you look at this lesion, you can see that there is an annular lesion with crust in the center. When you palpate these lesions, there is a lot of induration underlying this. This is very classical of cutaneous leishmaniasis or dum-dum fever. The Delhi boil or the dum-dum fever, that is the associations which you get. Now we have another question on the screen. We have a lady who presented with photosensitivity and following rash. Ayush, Rajlakshmi, Narmata, Rakesh. 35-year-old patient with photosensitivity following rash. What can be the diagnosis? Very nice. The answer to this question is SLE. This is a very classical malar rash. Why this is not anything else like rosacea? Because can you see the lesions on the neck also? Rosacea is only limited to the face, but when you see the lesions on the neck, on the lips, you can see, which is very classical sparing of nasolabial fold. All these points towards the malar rash of SLE. Next question. Tell me what can be the diagnosis here. What is the diagnosis here? Allergic contact dermatitis, herpes simplex, erythema multiforme, or drug rash. Allergic contact dermatitis, herpes simplex, erythema multiforme, or drug rash. What is the answer here? Very nice. The correct answer of this question is option number. It is allergic contact dermatitis to Bengal, which is clearly visible here. The only reason we have taken this Bengal in image is to show that because of the contact, the patient develops a lot of vesicles with a lot of erythema associated. Lesions seen in the rainy season, what can be the diagnosis? Piedras dermatitis, atopic dermatitis, flexural dermatitis, or dermatitis artifacta. Lesions seen in the rainy season, what can be the diagnosis? Piedras, atopic, flexural, or dermatitis artifacta. Anybody can tell me the answer. Very nice. The lesion in the rainy season diagnosis will be Piedras. That is actually an insect bite hypersensitivity. So you tend to get different insects which releases irritant, and wherever it comes in contact, it can cause irritant dermatitis. These lesions are mainly on the opposing surfaces. So can you see here? So these are the opposing surfaces, and because of this, they are sometimes also known as Kissing's lesions. Identify this procedure. You have an image. You can see that some long linear strands are shown here. So what can be the diagnosis? Raja Lakshmi, Nivata, Ayush, Samji. This is a very classical image of KOH smear. A very classical example of KOH smear. So identify this process. The answer becomes KOH smears. Next question. What will be the answer? Erythematous plaques on HPE shows collections of neutrophils in the epidermis, suprapapillary thinning, negative auspit sign. What can be the diagnosis? Inverse psoriasis, rheumatoid psoriasis, gutted psoriasis, candidal intertrigo. Very nice. The answer to this question is, see, all the features points towards the diagnosis of psoriasis. But if you look at this, the auspit sign is negative because there is no scale. So this is a variety of psoriasis which is known as inverse psoriasis or flexural psoriasis, where the auspit sign becomes negative. This question is a very nice question, but I think this has to be shifted little at the top for you to understand. Please tell me the answer. Please tell me the answer. A man having habit of frequent washing the genitals. Man with a habit of frequent washing in the genitals. He developed falling lesions since few days. What can be the diagnosis? Melanitis, fixed drug eruption, pemphigus, or lichen planus. Nice, all of you. Nivita, Ayush, Rajalakshmi. The correct answer of this question would be option number one. Now, if you look at this image, you can see a lot of fissures which is present. Can you see this lot of fissures which is present at the glance? So this is a patient with a very characteristic habit of washing the genitals, and whenever somebody washes the genitals, there is a retention of moisture. This retention of moisture can cause the growth of candida, giving rise to candidal balanitis. Next question. What is the answer of this one? A child with yellow papule on the lateral neck skin biopsy showed increased calcification with clumps of elastic fibers. What is the answer? Very nice, all of you. The answer is straightforward. You can see a lot of wrinkles on the neck. It means the elastic tissue is damaged. And whenever you have damaged elastic tissue, you can even get the deposition of calcification in the nerves or in the vessels, because you have elastic tissue in the vessels also. And it's a very classical feature of pseudoxanthoma elastic. We have ABCC6 gene defect in the patients of pseudoxanthoma elastica. And this would be the last question. A 55-year-old female gives a history of lesions in 6 years. What can be the diagnosis? Rajlakshmi, Ayush, Samji. The last question of the today's session. Very nice. Look at this lesion. There are multiple blackish nodules which are present on the lower part. This is a classical example of acral melanoma. It's a long-standing condition. You can see it just below the digits also, where you have Hutchison sign positivity, or you can see some discrete groups of lesions on the lower extremity. With this, we are done with the today's session. I hope you all have enjoyed this. I request everybody to subscribe the YouTube channel, that is Let's Crack Neat PG. You can also follow us on our Telegram group. The name is same, Let's Crack Neat PG. For any subscription on an academy, you might need a code, and that is Chesta10. This will give you 10% additional discount. Please give me a thumbs up if you like this video. Thumbs up. And also, please give me a, or please press the bell icon so that you can